The description gastric bypass can mean one of two possible surgically altered anatomical states. The cartoon on the left shows the type of bypass used to palliate gastric outlet obstruction and involves a side-to-side loop gastrojejunectomy. This video will concentrate on the type shown on the right, which shows the commonest surgical bypass for the treatment of obesity. This involves creation of a small proximal gastric pouch partitioned from the remainder of the stomach and emptying into an end-to-side gastrojejunectomy, which is reconstructed as a Roux-en-Y jejunojejunectomy to maintain continuity with the duodenum, pancreas, and biliary systems as shown. The jejunojejunectomy, commonly known as the Y anastomosis, may be created either as an end-to-side or a side-to-side anastomosis. This will present the endoscopist with either a 2-lumen or 3-lumen choice of routes to the papilla, as shown in this cartoon. While it is optimal to reach the papilla with a duodenoscope, as in this example, it is usually too short and too flexible to do so. New overtubes may facilitate this in the future, but most centers currently use a small caliber colonoscope, enteroscope, or double balloon enteroscope to reach the papilla, and either attempt ERCP with a very limited range of accessories or place a guide wire and backload a duodenoscope over it. In this patient, the typical 3 choices appear at the Y anastomosis, and the correct route to the papilla must be selected. It is often the most difficult of the 3 options. Once entered, the afferent loop is traversed with the assistance of external compression with a lead-gloved hand until the papilla is reached, a guide wire placed, and a therapeutic duodenoscope backloaded. External compression may still be required to insert the duodenoscope deep into the duodenum to access the papilla. Access and therapy are then similar to the reversed situation found in the Biliary34 patient, and here cannulation of the pancreatic duct is achieved, a guide wire placed, and a stent inserted. A reverse sphincterotomy is used to complete the biliary sphincterotomy. A guide wire is then placed within the bile duct and the procedure completed. This case demonstrates another approach by placing a guide wire transhepatically and using this to pass other accessories such as this sphincterotome, antegrade, or retrograde to achieve the desired objective. Endoscopic management of pancreatic or biliary problems after gastric bypass surgery for obesity remains a challenge.